everyone. Welcome back here at ESCMID Global TV. My name is Judith Cohen. I am your host here during the TV broadcast this year's ESCMID Global 2024. We're happy to have you back here in the studio with us, and I am very happy and pleased to introduce you to my next guest, who is live here in the studio with me. I will be speaking with Professor Mervyn Singer, who is a professor of intensive care medicine at the University College in London, and maybe more importantly for our viewers, will be holding a keynote lecture here at ESCMID Global 2024 in just a little under an hour, so
Indeed.
at 11 o'clock in Hall A. You will be giving your keynote lecture on redefining sepsis. Mm-hmm. Well, we're really interested to hear a little bit about the background of your topic, and just to have a little bit an idea of, or get to know you a little bit before all massively going towards your keynote lecture.
No, thank you very much. No, I've had a sort of lifelong enduring interest in sepsis. You know, I work in intensive care, and clearly it's a common problem we have and a common problem we're still battling with. And you know, the talk, it was lovely to get the invitation to come here, and what I was invited to talk about was to describe how sepsis, our view of sepsis has changed over the years. And so I start with a very sort of historical perspective. You know, it was initially described as putrefaction by the Greeks, and then the Romans took over, and it was just decaying tissue, and they had no idea at the time about microbes and organisms. A few people did suggest it in the Middle Ages, but I think the belief was it was all miasmas, toxic gases, that caused disease. And it was only, I suppose, in the 1850s, 60s onwards, with Pasteur and the germ theory, that people realized that actually bugs are important. And then it took off big time. Antisepsis came about, so Lister, who actually, where I work now, he was a student and a junior doctor, so there's a nice sort of heritage there. And then gradually people realized that actually bugs are important. However, it probably wasn't until about the 1980s, 1990s, that people then recognized that the host response, how our body abreacts to an infection, is the actual underlying cause of sepsis and organ dysfunction. And so there's been a nice evolution. So it's not just the bug,
but it's the body's reaction to the bug.
100%.
That's become more important.
No, it's, to my mind, the bug's the trigger, just like you can get a virtually identical picture from trauma or pancreatitis. So the bug's the trigger, and again, we don't fully understand why, but for whatever reason, the body goes haywire, and instead of just focusing on dealing with the bug, you get this systemic explosion of mediators, up and down regulation of pathways that eventually leads on to organ dysfunction.
So your title, Redefining Sepsis, is that we're redefining it from the ancient Greeks till now? Or do you feel like the definition of sepsis these days in the actual time needs a redefinition as well?
No, great question. I was involved in the latest sort of definitions, so-called sepsis 3. There was sepsis 1 in 1992, which brought into play SIRS, systemic inflammatory response syndrome. But then the penny dropped that actually inflammation is part and parcel of a healthy response to dealing with infection. And so there was a second iteration in 2001, which didn't really make any changes to the 1992 version. And then in 2016, we published Sepsis 3, where the emphasis was shifted onto the dysregulated host response. And that definition and the clinical criteria have sort of taken hold, and they've been actually widely accepted, but clearly it's not the end story. You know, we're still learning. Sepsis is an umbrella syndrome. And we're learning that within that there are different biological signatures. We have to personalize our approach. When a patient pitches up to hospital or comes into an intensive care unit, their biological signature may be very different from another patient who is clinically identical, and again, that evolves over the course of their illness. As a consequence, we're still way behind in knowing when to intervene, how to intervene,
Yeah.
how much to give, how little to give, when to stop. So there's a constant evolution. We're learning. I think we've made quite great strides in terms of understanding pathophysiology, but there's still a lot more to go. And I think also another problem is that we lack the tools to quickly diagnose at the bedside.
Yeah, so early detection is difficult.
Yeah.
Yeah.
And even
because
infection.
is the incidence, is it staying the same over the past decennium, or is it increasing? What are the...
Very good
How
question.
large is the impact of sepsis on an intensive care unit?
So I'm going to give a very qualified answer. Yes, it's there. Yes, it's common. The problem is, a lot of the time we can't actually diagnose whether there's an infection as the trigger. And there are quite a few studies showing that probably 20 to 40% of patients labeled as being septic actually probably don't have an infection. So unfortunately, there's a tendency to overdiagnose and thus overtreat.
Then it's not a sepsis, right?
Correct, but it's coded as such.
Yeah, okay.
And
So
so if
it's
you-
a person with multi-organ failure and
Yeah.
sort of acute host response.
Exactly.
Yeah,
And it could be
okay.
to surgery or
Yeah.
pancreatitis or whatever.
Yeah.
However, they're labeled, they're coded,
I
and that
get
goes
it.
into the
Yeah.
epidemiology.
Yeah.
But clearly, to be fair,
Yeah.
people are living longer. We're doing more and more to them, invasive surgery,
Yeah.
chemotherapy, immunosuppression. So these are the particularly at-risk patients. So certainly hospital populations now, the predominant group that get sepsis are those with some degree of immunosuppression. And that includes, unfortunately, old age. As you age, your immune system does decline. So you can see very much.
And how does antimicrobial resistance fit into this story?
Yeah.
Is that often one of the problems that you encounter on the intensive care unit?
Yeah, I think it's very geographical. So touch wood, at the moment the UK isn't as bad off as, for example, Southern Europe, Eastern Europe, Asia, North America, etc.
Yeah.
So I think generally Northern Europe's been more reticent about using antibiotics. And so at the moment it's not a huge problem where I work, but you can see it's gradually, year by year, increasing. And so clearly, if we can identify infection, and then identify bacterial infection, and then identify what bug we should give for that bacteria, then perhaps we can be a little bit more sort of cautious in the way we throw around antibiotics.
Yeah, but if I understand you correctly, the largest problem is the huge immune response occurring in someone's body. And are there enough, do intensive care doctors have enough tools to adequately treat it, or do you feel there's an unmet need there in the therapeutic area?
Oh, yeah, no, again, great question, great challenge. So what intensive care does is care. So that we have very few treatments. So yes, antibiotics to try and kill the trigger, source control, so the surgeon or the radiologist draining a abscess or a perforated bowel or whatever. But the rest of the time, we're literally doing nothing more than propping up the failing organs until hopefully the patient recovers. And there's been 30 years, unfortunately, of sort of abject failure in terms of trying to find new therapies. And I think part and parcel comes back to your earlier point about trying to identify if there is an infection, trying to understand the immune response, how, when, and in whom to intervene.
So the largest gain is probably to be found within early detection. Yeah.
And better characterization of the host response to the infection.
Yeah. So what are you hoping for your keynote lecture? Do you expect some interactivity because it is a lecture?
No, I'll be expounding my views and just giving a perspective historical to where we are now to where I hope we'll be in the future. And I think the future's bright. I think there's some amazing technologies coming through which, A, will give us rapid answers, because you've seen the difference it's made in cancer, where now you can home in on the type of cancer and tailor your treatment precisely. And that's where we need to be, but we can't wait days for an answer. We need it in minutes to hours, and so we need rapid diagnostics. Ideally, I'm biased as a clinician, but point of care diagnostics, and be able to repeat them so we can titrate our therapies, immunomodulatory, whatever, to that patient. And so they need to be rapid, reliable, and affordable.
Yeah, well, there are a lot of people working on that here as well. So
Indeed.
let's hope they
luck.
join you. Yeah. So on a more personal note, what are you visiting yourself during the Congress? Are you joining other sessions on sepsis, or because I believe you also had you called it a long-standing love affair with the mitochondrial.
Indeed.
Will that be some of the topics that you will be participating in?
No, I have a long-standing love affair with this little organelle. Again, I like asking simple questions. My research is, why? Is often a question I pose. And again, many years ago, a very simple question is, how does infection cause organs to fail? And when you actually look at these organs histologically, they look remarkably normal. You might see a bit of inflammatory cell infiltrate, but essentially you don't see swathes of dead tissue. So hang on a minute, you've got normal-looking tissues that are functionally not working. And so a lot of my research for the last 20-odd years has been based on trying to understand why this functional impairment happens, and the mitochondria seem to be key. So a lot of the signals that are sent out when there's an inflammatory hit, the body tries to fight, and if the body thinks it's not winning, it puts its head down. So the organs go into I liken it to hibernation, a state of dormancy. And so metabolism switches off, and they go into survival mode, where they're not functioning, but it's a case of marshalling resources, staying alive, in the hope that once the inflammation goes, they can then wake up, regenerate, start working again. So it's quite an interesting area.
Interesting stuff,
And then the secret is, can you come up with therapies that can influence this metabolic shutdown?
Well, there's probably a lot going on within these topics here this year. You're happy with the program?
I think rightly there's a huge emphasis on inflammation and immunity. But I think, again, this is a personal bias, but I want to push it one step down. Why do the kidneys fail? Why does the heart not pump well? So you have all of these actually very important problems we have to deal with. And we still don't fully understand why it happens.
Well, it's really interesting. Well, thank you so much for taking the time to join us here in the studio just before your keynote lecture. For our viewers, I can imagine this was a huge teaser and that you all want to join the keynote lecture now. It's in Hall A at 11 o'clock sharp today, so make sure you join if sepsis also has your interest. We will be back here at the clock of 11 with the new director of the AMR Action Subcommittee, Holger Rode, and the ESCMID Emerging Infections Director, Xavier Lescure. So join us again at 11 o'clock for a really interesting interview with those two people. See you then.